بسم الله الرحمن الرحيم. Dear colleagues, السلام عليكم ورحمة الله وبركاته. I am Dr. Fatma elWakeel, MD Cardiology, Professor of Intensive Care at Theodore Bilharz Research Institute, and I would like today to give you an overview of cardiohepatic interactions. This is my contact information. The interaction between the function of the heart and the liver can be classified into liver diseases affecting the heart, which are mainly three diseases: chronic hepatitis C virus, liver cirrhosis, and non-alcoholic fatty liver disease. Secondly, heart diseases affecting the liver, which are mainly heart failure, ventricular assist device, and heart transplantation. And finally, diseases affecting both the heart and the liver, which may be congenital diseases, metabolic diseases, or infections. To start with liver diseases affecting the heart. First, chronic hepatitis C virus. It can affect the myocardium, leading to myocarditis. Chronic inflammation of the myocardium may lead to necrosis and loss of myocytes, ending in dilated cardiomyopathy. Also, it excites myocyte proliferation, leading to hypertrophic cardiomyopathy. And the immune-mediated myocarditis and fibrosis, when it is confined to the subendocardium, can lead to restrictive cardiomyopathy. And sometimes it causes localized myocardial lesions of the right ventricle, leading to thinning or aneurysm of the ventricular wall and ending with arrhythmogenic right ventricular cardiomyopathy. Also, HCV can affect the coronaries as it causes vascular inflammation and metabolic abnormalities, and both excite atherosclerosis and leading to coronary artery disease. This illustration shows hepatitis C virus infection and cardiomyopathies. As we said, it can lead to myocarditis, dilated cardiomyopathy, hypertrophic cardiomyopathy, atherosclerotic right ventricular cardiomyopathy, and it can also cause left ventricular aneurysm. This illustration shows the mechanism of HCV-induced coronary artery disease. HCV can cause endothelial dysfunction and can lead to direct vascular invasion by the virus. Also, it increases the release of the pro-inflammatory mediators, and all can lead to chronic inflammation. At the same time, HCV leads to liver fibrosis and steatosis, which increase insulin resistance and causes downregulation of anti-inflammatory mediators adiponectin that lead to chronic inflammation also. And all can lead to increased atherosclerosis and coronary artery disease. The second disease, liver disease that can affect the heart, is liver cirrhosis. Liver cirrhosis can cause autonomic dysfunction, leading to hyperdynamic circulation. Also, it increases nitric oxide and endocannabinoids, leading to decreased systemic vascular resistance, with increased stroke volume and cardiac output with low systemic arterial pressure. It affects the systolic function as autonomic dysfunction with impaired beta-adrenergic signaling pathway and impaired baroreceptors and volume reflexes, together with cardiac myocyte dysfunction, decreased sensitivity to vasoconstrictors, and impaired function of L-type calcium channel, all can lead to impaired ventricular response to stress and exercise. Regarding diastolic dysfunction, liver cirrhosis causes myocardial hypertrophy, fibrosis, subendothelial edema, and abnormalities in calcium exchange through the sarcoplasmic reticulum. all can lead to increased ventricular stiffness and impaired myocardial relaxation. Liver cirrhosis causes some electrophysiological disturbances. It causes chronotropic incompetence with inability to increase the heart rate in response to stress. It also causes electromechanical uncoupling and prolongation of ventricular polarization, which is due mainly to impaired function of potassium channels, increased adrenergic drive, and increased estrogen, with prolonged QT interval and ends in arrhythmias. Liver cirrhosis can cause portopulmonary hypertension. The diagnosis of portopulmonary hypertension mainly depends on mean pulmonary artery pressure more than 25 millimeter mercury at rest, pulmonary capillary wedge pressure less than 15, and pulmonary vascular resistance more than 240 dynes. Also, liver cirrhosis causes hepatopulmonary syndrome, which is due to imbalance between vasoconstrictors and vasodilators, leading to pulmonary vascular dilatation at the precapillary and capillary level, with intrapulmonary shunting, ventilation perfusion mismatch, leading to hypoxemia and progressive hypoxia, dyspnea, and cyanosis. Imaging studies that can identify intrapulmonary shunting in hepatopulmonary syndrome include contrast echocardiography and perfusion scintigraphy. Pericardial effusion in cases of liver cirrhosis usually associated with ascites and can cause cardiac tamponade. Coronary artery disease. Previously, it was thought to be lower than in general population due to abnormal synthetic liver function with decreased cholesterol, lower blood pressure, and increased estrogen. But recent studies have demonstrated that liver transplantation candidates have a significantly greater prevalence of coronary artery disease than previously thought, and it should be evaluated before liver transplantation. End-stage liver disease patients with coronary artery disease have worse outcomes than patients without coronary artery disease. Serrated Cardiomyopathy. In patients with cirrhosis, a specific type of cardiac dysfunction named Serrated Cardiomyopathy has been reported, and this is independent of the etiology of liver diseases. Serrated cardiomyopathy is clinically asymptomatic in most patients, as peripheral vasodilatation will reduce the afterload and compensate for abnormal cardiac function. In times of stress, rapid hemodynamic changes with impaired cardiac response will produce symptoms of acute heart failure. Serrated cardiomyopathy should be suspected in patients with moderate to advanced cirrhosis, presenting with exercise intolerance, worsening fatigue, and/or peripheral edema, who have no history of cardiac disease. Heart failure secondary to serrated cardiomyopathy is the most common cause of death in patients who undergo liver transplantation. An altered diastolic function with a subclinical systolic dysfunction are the mainstay in patients with serrated cardiomyopathy. New echocardiographic methods and cardiac magnetic resonance might refine criteria for serrated cardiomyopathy definition. Electrophysiologic abnormalities with prolonged QT interval, chronotropic dysfunction, and electromechanical dysynchrony are supportive criteria for diagnosis. Treatment of serrated cardiomyopathy is non-specific, and the only effective treatment seems to be liver transplantation. This diagram shows the diagnostic criteria for serrated cardiomyopathy according to the World Congress of Gastroenterology in Canada in 2005. The criteria: in absence of clinically significant cardiopulmonary disease, the diagnostic criteria of the systolic dysfunction: EA ratio less than 1, deceleration time more than 200, and isovolumic relaxation time more than 80. And systolic dysfunction, the criteria for diagnosis: left ventricular ejection fraction at rest less than 55, or abnormal systolic contractile response to stress. And the supportive criteria are prolonged QT interval, chronic tropic incompetence to stress, electromechanical uncoupling, left atrial enlargement, left ventricular hypertrophy, elevated BNP and terminal proBNP, and troponin. This diagram shows us an example of liver cirrhotic patient with child C. Here is the pulsed wave Doppler at the level of the mitral valve, showing EA ratio more than 2. And this is a tissue Doppler with reversed EA annular ratio measured at the level of the mitral annulus. And here is the apical four-chamber view showing increased left atrial volume. And this panel shows the global longitudinal strain of the left ventricle, which is markedly decreased, suggesting a significantly decreased longitudinal systolic function. The third liver disease that can affect the heart is non-alcoholic fatty liver disease. Non-alcoholic fatty liver disease is usually associated with other metabolic disorders as diabetes, dyslipidemia, hypertension, and obesity, which all are risk factors of cardiovascular disease. Non-alcoholic fatty liver disease, in absence of hypertension, diabetes, or previous heart condition, lead to left ventricular diastolic dysfunction with impaired left ventricular energy metabolism. Also, increased liver fat can lower adiponectin level and increase the level of fibrinogen, C-reactive protein, plasminogen activator inhibitor, which all can lead to coronary vascular disease independent of body mass index and intra-abdominal obesity, and end in impaired cardiac function. Also, ectopic deposition of fat in the myocardium can lead to abnormality of the cardiac function. This illustration shows the adverse effect of non-alcoholic fatty liver disease. At the level of the coronary, it can lead to coronary atherosclerosis, ischemic heart disease. At the level of the myocardium, it can lead to cardiac dysfunction, cardiac hypertrophy, left atrial enlargement, and heart failure. At the level of the heart valves, it can lead to aortic valve sclerosis and mitral annular calcification. Regarding conduction system, a non-alcoholic fatty liver disease can cause AF, tachyarrhythmias, or certain cardiac conduction defects. The effects of treatment modalities of the liver diseases on cardiovascular system. Studies on interferon showed that it can cause cardiomyopathy, myocarditis, congestive heart failure, pericarditis, rhythm disturbances, pulmonary hypertension, vasospastic angina, microvascular angina, peripheral vascular disorders, stroke, and myocardial infarction. Studies on Sovaldi showed that bradycardia can occur with concomitant use of amiodarone. So it is not recommended to use Sovaldi with amiodarone. Transjugular intrahepatic portopulmonary shunt and liver transplantation can lead to rapid increase in venous return, heart failure, and pulmonary hypertension that unmask the presence of serrated cardiomyopathy. Heart failure, myocardial infarction, and arrhythmias represent a major cause of liver transplantation related morbidity and mortality, and being a leading cause of death. Cardiovascular risk assessment of liver transplant candidate. We must evaluate coronary artery disease, heart failure and cardiomyopathy, pulmonary heart disease, pericardial effusion, QT prolongation, left ventricular outflow tract obstruction, and the presence of patent foramen ovale. This is a suggested strategy for pre-operative cardiac assessment of liver transplant candidate. We must assess the presence of coronary artery disease, and if there is 2 or more coronary artery disease risk factors, the patient may go to coronary angio. If no, the patient will refer to do non-invasive ischemic heart disease test, and if it's positive, the patient may be referred to coronary angio. If there is obstructive coronary artery disease, we must postpone liver transplantation to consider revascularization of coronary artery disease. If not, we can proceed with liver transplantation. Also, we must assess the cardiomyopathy, heart failure, the presence of pulmonary disease, pericardial effusion, intracardiac shunts, and arrhythmias, and if present, we must postpone liver transplantation till aggressive treatment of any of them. Now we come to cardiac causes of hepatic disorders. Heart failure. Chronic heart failure or backward heart failure can lead to hepatic disorders. As right ventricular dysfunction increases venous pressure, leading to atrophy of hepatocytes and perisinusoidal edema, with enhanced hepatic lymph formation and ascites. Also, stagnant flow lead to thrombosis within the sinusoid and hepatic venules, and leading to liver fibrosis and liver cirrhosis. Causes of congestive hepatopathy. The main causes are constrictive pericarditis, severe pulmonary arterial hypertension, mitral stenosis, tricuspid regurg, cor pulmonale, and ischemic cardiomyopathy. Signs of hepatic congestion: jaundice, dependent edema, ascites, hepatomegaly with hepatojugular reflux, and pulsatile liver in patient with tricuspid regurg. Lab features: usually there is increase of gamma glutamyl transpeptidase, alkaline phosphatase, bilirubin. Transaminases may be normal or moderately increased. Usually there is a prolonged prothrombin time and reduced serum albumin concentration. Treatment is the treatment of the cardiac cause. Acute heart failure or forward failure. Profound systemic hypotension due to acute cardiopulmonary collapse after myocardial infarction, exacerbation of heart failure or pulmonary embolism can lead to ischemic liver injury with increased liver enzyme and prothrombin time. Forward and backward factors often coexist. Left ventricular assist devices. Left ventricular assisted devices usually improve liver blood flow, improve liver function in patients with mild abnormalities pre-implant. But sometimes liver dysfunction can occur or worsen after the implantation of left ventricular assisted device. Due to large doses of vasopressors, prolonged cardiopulmonary bypass time, arterial hypotension, systemic inflammatory responses, and many right ventricular failure, which all can lead to liver damage. Heart transplantation and its effect on the liver. Chronic cardiac hepatopathy is common in patients evaluated for heart transplantation, and liver dysfunction predicts the adverse outcome following transplantation. So, assessment of liver function and detection of liver cirrhosis is required in all candidates for heart transplantation. Patients with chronic hepatitis C or B should be treated before heart transplantation to avoid antiviral drugs intake after heart transplantation, which may be associated with graft rejection. Patients with heart failure and irreversible cirrhosis could be offered combined heart and liver transplantation. Finally, diseases that can affect both the heart and the liver. It may be congenital diseases as Algiant syndrome that causes chronic cholestasis, congenital heart disease, eye abnormalities, characteristic facial phenotype, and butterfly vertebrae. Infections also can affect the heart and the liver. Cytomegalovirus can cause myopericarditis and can cause hepatitis. Metabolic causes, Wilson disease, which is disorder of copper metabolism leading to accumulation of copper in the liver, brain, and other tissues. It can lead to left ventricular thickening and diastolic dysfunction. Hemochromatosis, which is inappropriate absorption, which is due to inappropriate absorption and deposition of dietary iron, leading to hepatic and non-hepatic end organ injury, leading to liver cirrhosis, diabetes, arthritis, skin pigmentation, and cardiac diseases. And iron overload the myocyte reduce left ventricular distensibility, leading to the autoimmune diseases. The atypical clinical presentation of Graves' disease, like anemia, vomiting, jaundice, also can affect the heart and can lead to right heart failure with pulmonary hypertension. Chronic alcoholism can affect the heart and can affect the liver. It can cause dilated cardiomyopathy. Thank you, and looking forward to see you next Saturday.